To get us started, I'll go ahead and ask the first question, and I will carefully avoid the word value, although it would be tempting to use it in this sentence, which is, we've kind of had a smorgasbord here of different perspectives, and I'd like to just kind of pull it together with one question, which is, as this incredible panel thinks about the future, what gives you optimism that we're really going to improve on the three measures of access, cost, and quality? And I'd love for a volunteer to go forward. Bob, and then Mike.
One of the most exciting things, I think, is the data liberation that I referred to. And as a doctor, I remember the first time I got a report card from a health plan when I was a doctor at Beth Israel Deaconess in Boston. I got a report card from Tufts Health Plan that said, "Dr. Kocher, you're a Harvard doctor. You're average." I remember calling the chief medical officer of that health plan to ask for the data because it must be wrong, that I cannot possibly be average. I'm far above average in my mind. And they sent me the data, and the data actually was right. I was average on a bunch of measures that they were measuring me against that I wasn't aware of, and I got better quickly. And I took that observation from many years ago with me, and one of the most interesting things today is I'm a professor at Stanford, and we're a Centers of Excellence hospital for almost every insurance company. So if you get sick in California and you have cancer or need a bypass surgery, you're told by your insurance company, go to Stanford. Then I think about what happens when that happens. You might get me. And you don't know if I'm above average or below average. You're just told that Stanford's awesome. And it so happens that when you look at the data now, which you can do in California, you can do it actually in every hospital in America, look at the doctor data. What you'd find is that if you needed a bypass surgery, there's 4 doctors at Stanford that do more than 80 of those surgeries a year, and 3 of them are awesome. Risk-adjusted, well below average mortality. I would assure you that your outcomes are going to be great. I would go to them. But one of them's terrible. And there's no system today for that doctor that's 4 times worse than the California average risk-adjusted to protect you for getting that one. And one of the most interesting things, I think, is the idea that we're going to start doing this doctor-patient matching much more carefully. I would tell you as a doctor, we are all good at some things and not good at the other things. If you saw me for what I'm good at, I'm awesome. You saw me for everything else, I used up-to-date, and I hope I was average. And the most important thing is actually this pairing, and data allows it to happen. I assure you that, like, when I referred, I do my best to send you to the right doctor for you, but my brain's not Google, and it's not a database that actually looks at the actual outcomes, and now you can. And so that's something that I'm really excited about seeing applied. I think health plans, kind of what Jeff said about, you know, if Amazon did it, like, there'd be algorithms that would be a lot more informed than the way we refer patients today, and that will save a ton of morbidity, a bunch of mortality, and a lot of money, because actually better outcomes are cheaper. That's one of the coolest things about healthcare, is that it's cheaper to do the right thing than to pay for the complications. So I'm excited about that.
Governor Leavitt?
I'm optimistic because I believe we are beginning to do hard things. We have operated under a payment system that most in the health business have mastered how to, the word is optimize, which is another word that I am confident an economist could have a field day with. But they have learned how to optimize the coding and to optimize the payment in the system, and therefore we get what that produces. Figuring out how to change that is hard. Figuring out the relationships on where people are in the system. Figuring out systems, like Bob mentioned, to actually evaluate whether a person is average or above average or below average. It's hard. We are pioneering. In the same way, Jeff mentioned businesses that have invented new processes. He mentioned Bill Gates and his capacity to put his goal to put a computer. What made that happen is the internet, and we have now figured out in society how to do very hard things. Well, I think, given the fact that we are being driven not just by a noble purpose, but by economics now to do hard things, that there's reason for optimism. It won't happen quickly, but it is happening, and I think we will ultimately end up with a uniquely American healthcare solution that will make a better system to serve people.
Anyone else want to take it? JD?
We were laughing earlier. Dr. Reinhardt found an article of a mother who was charged for holding her baby during the delivery. It showed up as an itemized bill. What was it, $40 for $39 for skin-on-skin contact. The inefficiencies in the current system are so dramatic that it's reason for optimism. You all know it. You have it in your own lives. My wife and I just had a baby. We got charged $6,000 for the audiology test. We're in an in-network hospital. Turns out the audiologist is an out-of-network troll. Right, it's the same test that you and I can perform by clapping. The whole thing took about 4 minutes, and it's a $6,000 bill that you get hit with. Right, you've all had those experiences. I guarantee you had in your own family lives, and it's that level of efficiency that gives us optimism. You can improve on that for sure.
You know, Nancy, I would say that there's widespread acknowledgement that healthcare is not what it should be. It costs too much. The quality is not what it should be. There's a lot of waste, and the experience is not good. And I think that awareness alone is really reason for optimism. And that awareness leads to more unconventional approaches than we've seen in the past. I agree that we're on the verge of some really heavy lifting, enabled by greater engagement in the ecosystem of healthcare. That is, all participants are leaning in ways they haven't formally. And we have the data today and the technology, not in the exam room so much, but the technology to examine the data to actually make hard choices about the care that should be delivered. So I think there's good reason to be optimistic, but we have to address the cost side of things to make it successful.
But do you want to take it as well?
I also am optimistic. First of all, having lived here for
Turn on your mic.
I think life in the U.S. has gotten better over the 40 years I've lived here. I mean, we hear all this talk about with going to hell in a handbasket. I don't actually see that at all. I think life has gotten better, and healthcare has gotten better, and it gets better every year, I think. There are, however, some strange things that we do, which I hope will be so uniquely American. I told Nancy yesterday, I'm thinking of writing a blog post. What if I took a random sample of Princeton freshmen, got them really drunk, and then at 4 in the morning, have them design health policy? Would they ever come up with something so stupid as to pay oncologists 6% of the price of a drug they use, so that the more expensive the drug they pick, the more money they make? Even a bunch of drunken freshmen at Princeton wouldn't come up with that. They're not that ridiculous. And you can go, yesterday we had 4 or 5 of these instances where in the US health system, we do things that is just plain idiotic. And they could be fixed very easily, but because of the political powers of people, et cetera, they don't. I hope at some point we will focus on those and get rid of this. And this out-of-network, I personally, when I first heard about it, I was chair of a commission on hospitals in New Jersey. I actually didn't believe when people told me this, because I said no one would be this ridiculous, that you could actually be in a hospital, in network, and the doctor says you need an MRI, and the radiologists are out of network and can hit you with whatever they like. It's such an idiotic idea that you really wonder, would a bunch of drunken freshmen ever think of that? So those are the things that we could get rid of that would immediately make healthcare better for patients outside of the clinical side. I think the clinical side has much improved, although they're good and bad doctors, good and bad professors, good and bad for everything. Overall, I think U.S. healthcare, the quality is pretty good.
Great. So instead of going to the reverse question, I was going to ask them what's keeping us back. I think we all know the answers to that. I'll go ahead and start doing your questions. These are going to jump around a little bit, so I'll throw them out and I'll just ask for volunteers. And the first one is, why is reference pricing not used for services like joint replacement more widespread? CalPERS experience. So I guess what they're asking about is, why hasn't reference pricing taken off, especially for procedures that are more defined? Would anyone like to take it?
I don't know. It makes great sense, and it's something that from a policy perspective, we thought, I think, was going to take off, particularly in the private sector markets. When you look at price variation for all procedures, it's typically 400%. 400%. And when you look at quality outcomes, there's great data now that suggests that there's no relationship between price and quality. And so it makes perfect sense that you could draw a line and be like, okay, colonoscopies, we're going to pay up to this much. There's a lot of supply below that price on Uve's supply-demand curve. Go to it. I think employers have been a little bit reticent to ask their employees to A, care about the price, B, potentially drive somewhere differently, or C, tell their doctor that the person that they suggested that they go to is above the price and have that conversation. And then D, most doctors, when they make referrals, have no idea if the person they're referring to is above or below the price. So I think it's probably operational considerations that have made this sort of obvious policy. It's one of the policies that I think the Princeton freshman would have suggested would be a good idea, not take off as quickly as it could. I think it will. I think it makes sense.
But did you want to take it?
You know, just at this moment, there is a huge email list that Peter Grant supports, and there was a big tinkling match among us policy wonks over the question, why don't good ideas scale up in the U.S.? And two highly respected colleagues, I don't want to mention their names here, came out with the research. They're both sociologists. They say it's cultural diversity. It's just simply that you have different cultures, and what works in California can't work in Florida, and so on and so forth. But when I step back from, cultural diversity explains everything and nothing, because you can explain almost anything with that. I was stunned by that because this is a country that invented one-size-fits-all, Starbucks being an example, Holiday Inn, Marriott, McDonald's. We invented one-size-fits-all in this country. No other country ever had that. We exported it to them. Even universities are very similar in what they do. Yale, Harvard, Princeton, Berkeley, Chicago, you name it. We do the same things, teach the same stuff. Why is healthcare so different? And one of the explanations I came up with is because the payment side has been too accommodating. If, within the same city, you could have price variations of a factor of 5, and yet they all get paid. One hospital gets paid 5 times as much as another for a normal delivery. And if that's the case, why would you bestir yourself to be efficient and scale up? Because reference pricing is not that easily done. And it has some, it basically says rich people can go wherever they want and poor people have to go where the low prices. It's highly controversial. The drug industry hates reference pricing in the U.S., so it's not so clear why people in Florida would embrace it. But if they had to, if they were forced to by employers to embrace it, they would. They would, as Americans are very adaptable when push comes to shove, but push never came to shove.
Jeff, did you want to take a question?
Yeah, I'll just add one thing to that. I believe the individual market is a laboratory for things happening in healthcare that can be applied to the employer market. And that's for better or worse. And as an example for that, there's been a lot of criticism of narrow networks. And yet in Washington, when Premera entered the individual market in 2014, we did so with a narrow network and captured 50% market share, which told me that consumers were more than willing to make a trade-off on access for cost. And I think based on the experience you've seen around the country of carriers pulling out of whole states or counties at least, there will be further experimentation with ideas like reference-based pricing. And I think as proven in the individual market, they will expand beyond that segment.
Oh, Mike.
I think, again, we have to acknowledge this is very hard. And it's not going to happen quickly. I think it's important to think about this transition we're in as a 40-year process, not a 10 or a 12-year process. And I would argue that we are 25 years into the 40 years. All that was mentioned earlier today about what happened in the 90s and going through the managed care, and all of that was a learning process because we're changing fundamental business models and we're changing the way people are incentivized to do their work. Whoever it was that said one man's waste is another man's living is absolutely right. And so it is a mix of sociology and economics and politics. And doing this is not just a matter of deciding, it's a matter of implementation. And it's very serious. So I think it's safe to say that we are transitioning, but we're inventing as we go, and we're in a 40-year process, and we're on our way. A lot of the stupidity that's there has to be revealed, and it has to be fixed.
Mike, that's a great transition to the next question, which is, how will medical school residents and students pursuing a degree in healthcare be prepared for these transformations in their education? And anyone want to take it? Bob, you're the only one who's gone through medical school.
They should take my class, and then they'll be better prepared. I wish in medical school they taught us how to manage other people, how to engage a patient and influence their behaviors, what a pharmacist, nurse, social worker, care coordinator, intensivist, hospitalist, SNFist all do, and what's your role in that. Because today we have lots of people complaining about EHRs and the HITECH Act not solving that problem and not completely fixing the communication and sharing of information such that patients get care that actually works well from the patient. And so I think some of the things that I'm seeing is the mixing of classes in medical school such that doctors and other clinicians are trained together both in the didactic section and on the clinical rotations. I'm seeing many medical schools that I give lectures at teach basic data analytics and a lot of the things that you learn in business school about managing other people, giving feedback, having conversations, making eye contact, all that stuff. And so I think that we're on the beginning of the redefinition of how you teach doctors to work. But doctors increasingly are going to be managing teams that care for patients and have to actually care differently for different patients, back to the Starbucks analogy. So a sick patient needs different types of care, different engagement, different understanding, and different shared decision-making than a younger, healthier patient. And so I think that there's a lot of imagination to be applied, but I think we're recognizing, particularly because many now medical schools are ACOs and actually have populations they care for, we're waiting to see it. I think that a lot more of the school should be done in the outpatient setting in places like primary care clinics and community healthcare clinics, because that's also where you learn about what it's like to be a patient. The last thing I'll say on this is one of the most important things I've ever done was I spent a day living with a patient who had chronic diseases in her house, and she was a single mother with 2 kids, and she had a pill box with 90 different slots with her pills in it and a calendar that had all of her doctor appointments and lab visits on there with her work schedule. And the thing that it impressed upon me is that it is super hard to be a patient, and nobody wants to be a patient. And that what we ask the patients to do is probably impossible relative to her living a life that's joy-filled and supports herself and her family. And when you understand it kind of in that dimension, you appreciate, A, all the things others can do to make care better and how important the team is, but you also understand that what you have to consider, like what you're asking someone to do, because we often blame the patients for a readmission or for a failing to achieve a clinical outcome. And when you see what a patient actually has to do when they have a condition that's hard to manage, you realize that we're doing our best just to try to make them suffer less and that you have to rely on others. And so I think that's an important part of what teaching doctors should be in the future is actually thinking about what we're asking the patient to do. And I hope, back to the 40-year journey, that medical school is a lot more like that in 40 years than it is today.
That's a nice transition, and this question I'm going to call on you, JD, which is, do you envision that the healthcare system, plans, and providers will start designing using alternative payment models that try to address non-clinical social determinants of health, housing, food insecurity, and employment? And I call on you because of your program that you spoke about.
Oh, goodness. So I would absolutely agree that those, including those other spend categories, are key to managing the cost curve over the long term. And it's, ironically, it's actually easier the big government programs. It's easier when you're dealing with the state government because they, particularly we talk about some of the subpopulations, we've got categories of individuals, I guarantee you do in your own state, where if you add up all of the spend, cost of education system, all the social service departments, all the healthcare, you're spending well over $500,000 a year on some of those families. And again, the quality of care, the quality of service is awful, right? If you had to live in their shoes, it's a terrible experience. You got to go program to program. You may have 7 different care coordinators across each one of those programs. So it's absolutely key. Ironically, it's actually easiest, I would say, with the state government programs. Is it going to happen anytime soon on the commercial side? I'm not sure it is. Others at the table may have opinions on that, but that's certainly where it's at.
Mike?
While I was governor, I actually experienced this. We would have we had many families, and we knew their names, and they would have 6 or 7 different care coordinators, if you will, or program managers, and we would put them at a table, and they would begin to talk because none of them knew what the others were doing. And I do think, particularly in Medicaid, that we're very close to seeing a point where Medicare, particularly payers who are managing this, or providers who are managing this and being in some form at risk, are going to ask to have the ability to bring, and we're talking about transportation, we're talking about work, we're talking about, in some cases, juvenile court. There's a lot of different services that could be wrapped up and served much, much better than either the state or the Medicaid providers now providing them. And now that they have a financial stake in it, I don't think we're very far away from seeing people being willing to do that.
Great. Somebody submits this question. I did not hear the panel discuss 2 important topics, 1, prevention and wellness, and 2, non-clinical cases. I think we've just covered that, so let's focus on the prevention and wellness. Does anyone want to talk about the role of prevention and wellness as we look to the future?
Well, I think, obviously prevention of illness means you're just buying more quality adjusted life years than you would otherwise had, which is a good thing. But people who think that'll save money or lower healthcare spending in the future, almost all the research I have seen says no, that it won't do, because in fact people will live longer, consume healthcare more, and in the last 5 years they will rack up a huge medical bill anyhow. So the idea for preventive care somehow being a solution to the healthcare cost crisis, I would reject from all I've read. The idea that you get more quality of life years is a good thing, which therefore I support the idea of preventive care. Some of the wellness programs in corporations remain controversial, Bob. I don't know what you know about it, but from what I read in the literature, sometimes it works. I think Johnson & Johnson was said to have a very good program like that, but others had not such good experience. Maybe you can say something.
Yeah, I agree with your summary. The problem with wellness and prevention is that it works sometimes. And so in this room, some of you right now, if I talk to you about changing your diet, you'd be intrigued, and then you would. And for some reason, you would remain in your new diet forever, and you'll be healthier. Most of you, when I talk to you about how to change your diet, will politely nod and try it for tomorrow, and then go back to what you liked before, because that's what you like. And there wasn't that moment in your brain where I rewired your neurons and changed your serotonin levels enough to make you stick with it. And so then if I spend $800, like a lot of employers do, to try to get you to be more well or prevent something from happening, that money's wasted because you weren't susceptible to that change. And all these programs suffer with engagement curves that basically always start with a flurry of balloons and announcements and contests to get a bunch of employees to start something. And then if you look 12 weeks out, you're very lucky if you have more than 3% of the patients or the people doing it anymore. And then when you say, well, what's the value, sorry, Uwe, what's the cost savings that comes from those people doing that this year, it doesn't pay for the program. And that's sort of what the data says. But for those who do, they're evangelical, transformed, happy people that are more well and happy that tell you should do it some more. And so you sort of get this perpetuation of these programs that aren't that effective because we can't figure out how to actually make anybody's behavior change. And BJ Fogg at Stanford gives all these lectures about how you do it, but we haven't cracked that code. Nothing is as engaging as Facebook or Candy Crush for that matter. And until we have healthcare wellness and prevention programs that actually are like consumer products in terms of their engagement, they're probably not going to be cost effective.
I say Uwe and Mike.
Yeah, I once read a story about a patient whose doctor gave him all kinds of advice of prudent living. And in the end, the patient said, you know, doc, I'm willing to do all this stuff, but will I actually live longer? And the doctor said, that I don't know, but it'll certainly seem longer.
Well, consistent with that, I'll just say two things. One, while I was Secretary of Health, best I can calculate, we spent about $600 million trying to affect in a positive way obesity and to change people's habits. And actually, midterm through those programs, they were discontinued because we couldn't see any particular gain from them. Second thing I will say is that some months ago, I was in an airport, and it was about 10:30 at night, and I'd had my plane delayed 3 times, and the only thing that was going to fix it was a Big Mac and fries. And I got to the counter, and I felt this kind of wave of anger come over me because someone had, it was in a state where they had required there to be not just the price, but the calories. And it interrupted.
That's the Affordable Care Act working for your health.
Well, and it changed my behavior. And it didn't cost $600 million. I think there are things that society can and should and will do. I think the efforts we're making to begin to connect premium pricing with various health measures beyond tobacco, I think it's a very positive thing because it is beginning to change, to make people aware and to change behavior.
Let's turn to Medicaid for a moment. So what does the future hold for Medicaid expansion under a Republican or Democratic administration? What are the prospects for Paul Ryan's block grant proposal, and what would it mean for states already facing budget pressures? Anyone want to tackle either the need for Medicaid expansion or the likelihood of it? JD? As our Medicaid expert.
Tennessee's a state that our governor championed Medicaid expansion, but it was not embraced by the legislature. We're big proponents of it. Our mission is providing health care to Tennesseans. It's the right thing to do. That said, there are real challenges for states with these programs, and everybody knows it. They're massively cumbersome. They're fiercely anti-cyclical. Just when your economy goes down as a state, these programs tend to swell in their enrollment, and states can't print money. And we see it time and time again. If you look out over any long period of time, states get in trouble with these programs, and they end up having to do terrible cutbacks. So we're big proponents of Medicaid expansion, but there's got to be some innovation. There's got to be more waiver flexibility in order to do them in ways that are fiscally responsible if they're going to be stable, if they're going to serve the populations they need to serve.
Anyone else want to take it on? No. All right. So we'll have one more question on the ACA, and that is, as you look forward, and Bob, you did a great job kind of summarizing some of the great things that the ACA has done. But when you look forward, what about the stability of the exchanges and remedying some of the problems people are seeing with it, especially when we have such a divided country and the view of it is so mixed out there. And of course, we have a very divided Congress as well. Trump, Clinton, it doesn't matter. We're in a very divided way. What's going to happen to the future of the ACA? Mike, you're so brave. Thank you, Governor.
Again, I think we have to think about this transition we're in as a 40-year proposition. And there will be ongoing iteration for that entire period. And I would doubt there is a Congress in the next 15 years that will not have substantial work to do in the context of continually iterating this process. Now, there are some philosophic divides that clearly we confront, and we won't know how that will play out in this next iterative cycle until after the election. But I think it's important to acknowledge that there is progress being made, and there's an argument over whether that was because of the ACA or because of the unintended consequences of the ACA. But iteratively, we're moving it forward, and that's what we had the optimism conversation earlier, and that's why I'm optimistic.
Can I get Jeff in there, and then I'll come to you, Bob?
I just comment that very few things are ever written once and never change, perhaps the Ten Commandments. But when the ACA was crafted, I don't think anybody thought, Republican or Democrat, that it would never be edited again. It would never be tweaked, modified, improved. There's been no other piece of public policy in American history that Congress hasn't actually, over time, evolved and changed. And so I'm hopeful that we'll get to a point where we actually do make constructive improvements to the ACA, because you learn as you implement a law and see what happens in the economy, and you learn how to make it better. And so I'm hopeful that we'll begin to do that and stop sort of rancor about whether or not we should have it at all and get on with the 40 years of making it better.
Jeff?
Well, there are two calculations around the ACA. One's political and the other's economic. So in this town, it's generally on the former, but in JD's in my world, it's on the latter. And we have to think about the financial aspects of the ACA. And I think that while we're on a 40-year journey, there are some harsh realities coming in the next few years, absent changes that Bob's described. And that as health plans, we're faced making those decisions, and those will come very fast, very soon. For instance, in Alaska, we're the last carrier standing up there. Everybody else is pulled out. And absent a $55 million appropriation by the legislature and governor there to establish a reinsurance pool for high-risk individuals, it's likely there would be no carriers in that marketplace. And that's in part because the market's so small. Alaska's unique in that regard. But because there are a lot of loopholes in the law, too. So, again, to the extent improvements are made, that's a place where they need to happen. And I think that scenario is playing out all over the country. You see companies making that calculation about whether they can be profitable in the individual market long term, or even short term, frankly. So I think there's aspects of the ACA that could be in jeopardy in the next few years if there's insufficient movement in this town.
JD?
Just let me emphasize one point that Jeff made. April 2017, that's when most of us submit our bids for the next calendar year on the Affordable Care Act. That's not so many months away. In most states, the Blues are the only plan left, or one of a few. Collectively, by my math, the Blues system has lost over $6 billion on the marketplaces since they went live 3 years ago. There are some real fixes that are needed, and we don't have much time. Most of the CEOs in the Blues system, or anywhere in the system that I talk to, are saying maybe one more year is all I can hang on, which means some of those fixes need to be very quick in coming before that April 2017 date.
Uwe, we're going to give you the last word on this, and then we'll wrap up.
Yeah, there is unfortunately a lot of demagoguery around this, particularly against the insurance industry. The fact is that if you have a commercial insurance industry, for-profit or not-for-profit, it doesn't matter, and you tell them by regulation, you have to charge the same premium to people, to applicants, whether they're very sick or very healthy. That is an actuarial nightmare from a commercial point of view. In fact, it just cannot work. How do we know this? Well, we had it in New Jersey, where we had a community rating for the individual market, but no mandate to be insured, and that market pretty much collapsed. There was an article in Health Affairs by Monheit that demonstrated that. New York had a similar thing. I think in the end, per month, it was $6,000 per family, because only very sick people. People have to understand that unless you can force healthy people into the exchanges, as the Swiss do and the Germans do and the Dutch do, unless you can do that, this system is very fragile and unstable, unless either you're willing to raise substantially the federal subsidies to the insured, because most of these people will be sick people and the healthy won't be in there. And secondly, think of a reinsurance mechanism that works better than what we have. The Swiss have that. It's not perfect, but it's better than ours. The Germans have it, the Dutch have it, and here we're litigating over the risk corridors. So in some way, there is sabotage of what we have, and secondly, the mandate is too weak. Even though we have this age band, I think you want to go from 3 to 5. I don't know how much that'll do for you. But it is a tricky thing to have community rating, as that's called, with a very weak mandate, and sort of somehow blaming it all on greedy insurance companies, I think shouldn't be done, because it doesn't go to the actuarial problem the insurer really faces.
That's going to have to be the last word. You all have been an incredible audience to hang in here to the end. Look at all these questions that you submitted. We weren't able to get to them. I do have a couple of thank yous, if you could just wait. I'd like to thank Congresswoman Diane Black from Tennessee's 6th District for sponsoring our event. I'd also like to thank my amazing team, Catherine Sontera, Katie McDonald, Carolyn Myers, Kate Ellis, Kristen Wade. They've just done a terrific job for us. Most importantly, I'd like to thank our amazing speakers, so please join me in a round of applause for them.